between oral and systemic health. My name is Linda K. Tyler, and I am the Director of Business Development for ASDA. And I am so pleased to welcome PDS Health as a sponsor of this programming tonight. We're glad you've joined us this evening as we have an informative and interactive presentation planned for you. During the presentation, we will allow time for questions, so you'll be able to submit that through the Q&A feature. And I would like to take this time now to welcome Dr. Nusha Najafi and share just a little bit about her. Dr. Najafi is a multi-practice owner in PDS Health with PDS Health and has been practicing dentistry for over 10 years. She obtained her undergrad degree in psychology, natural sciences, and gerontology at USC and graduated from New York University College of Dentistry in 2008. Based in California, Dr. Najafi serves as regional clinical leader for oral DNA, salivary diagnostics. Her passion lies in educating patients about the mouth-body connection and takes great pride in introducing her patients to new technology while providing compassionate care. Please join me in welcoming Dr. Najafi to tonight's webinar.
Thank you so much, Linda. I appreciate the beautiful introduction. Welcome, everybody. I'm happy to have you this evening and excited to share some of my passion with you. Let me begin to share a little bit more about myself. I've been practicing since 2008 in Southern California, and I believe dentistry is a field where we're constantly learning and growing. And I wanted to come here today and share some of the technological advancements that we have and some of the information that I've learned recently about the mouth-body connection and how it affects overall health, because I truly believe this is the future of dentistry and definitely the future of medical dental integration in healthcare. So let's get started, and feel free to ask questions anytime. I know we'll save some time towards the end to ask some questions as well. So here we go. Let's go to our first slide. What do we want to do? Well, first I want to start and give you some of the background on what we're talking about and what bacteria we're actually looking for. And that's important. There are over 700 bacteria in the oral cavity, but there are 11 that we're directly interested in because these 11 periodontal bacteria have direct links to your systemic health. So we'll be talking about bacteria that's SRP resistant, which is scaling and root planing resistant, and what is transmissible and contagious through horizontal transmission. We also want to dive deep into what we have our tools in our tool chest to actually deal with patient care. And some of that is new technology. I am lucky enough to have beta tested a new program, which is a machine called an oralizer that tests an enzyme called AMMP8 that exists in the saliva. We'll be talking about that technology as well as oral DNA, which is another avenue of testing saliva. I also wanted to give a couple case examples where I'm integrating the two types of saliva testing in addition to the CBCT technology that we have, so you'll understand how you can implement this into your workflow in your daily practices once you start practicing out in the real world. Lastly, we want to talk about the future of medical dental integration and what you can do today to try to change your mindset in patient care and how to improve and develop in this exciting new field. So let's get started. So this is just a formality. Questions, feel free to ask them. I will answer them as to the best of my ability. If I feel like the answer is coming up, I'll also refer to the next slide that's coming forward. So let's get back to the future and what we're talking about today. Hundreds of years ago, a whole bunch of medical doctors got together and decided to separate the head from the rest of the body. And nobody ever communicated after that. And that's a huge problem because the mouth is the gateway to your overall health. And we're starting to realize that. And the tide is starting to change. And everybody is starting to realize the significance between the two fields. Back in 2000, when the Surgeon General released a report saying that oral health is integral to general health. And now as we go through, we're understanding that this is so important. And this is why we want to spread this message today so that you understand how you can make a difference in your patients' lives. So what is the commonality that we have here? Inflammation. Inflammation is the silent killer that everybody talks about. So, what is inflammation? Is it good? Is it bad? It can be sometimes confusing. Well, the truth is, it's both. Inflammation is good when it's short term and it's acute. It's your body's response to disease or trauma. You need it in order to repair yourself. The problem lies when inflammation becomes chronic. And how does that happen? It's where the body cannot get rid of the disease or the bacteria or the pathogen. It continues to fight, and as it continues to fight, the acute inflammation becomes chronic, and the chronic inflammation stresses out the body. As dental professionals, we need to figure out how to work together with medical professionals in order to decrease the amount of inflammation each patient has. And we're going to talk a little bit about the medical background and the dental background and what you can do as a clinician to decrease inflammatory levels. This is my favorite slide because it really puts oral health in the center of what it is. And for right now in today's talk, we're going to talk about the 5 most important areas of systemic health that periodontal disease affects. And you can see all of these listed. I'm going to give specific case examples on each of them, and then my information is listed at the end of this presentation. If you have any additional questions, we can go through. I have lots of case examples, but I had to limit them to our short amount of time so we have enough time to discuss everything that's important. So just some statistics for you to be aware of. And this is common knowledge now, and this is something that we have created an informational book in my practice that we leave in the waiting room and in the operatories for patients to be able to read the facts of the links between their mouth and their body. A lot of times patients just don't know and they don't have the information, but I wanted to share some of the major points to you. And this might be a little bit repetitive for some of you that have already seen this slide, but the more you realize the links and actually speak to this out loud, you start to realize how important this field of dentistry is in overall health. So let's get down to it. Periodontal disease double to triples your chance of cardiovascular disease. This is huge, and we have a slide that will detail the different bacteria involved. Some of them are periodontal bacteria, but bacteria from failed endodontic lesions can also increase cardiovascular disease and cardiovascular infarctions. Next, we have a co-bidirectional relationship between diabetes and periodontal disease. That's basically just a fancy way of saying if one is bad, the other one will be worse. If you improve one disease, you'll see improvement in the other. So it's important to review family history, see if there's family history of diabetes, check to see if someone is pre-diabetic, and discuss their periodontal disease with them and how that could affect their systemic condition. Pregnancy. I have a great example here on how pregnant women suffer from periodontal disease or pathogens that they are unaware of could negatively affect their pregnancy. We now are in a society where people are waiting a lot longer to start family planning. Infertility is something that's discussed regularly. There are direct links to oral bacteria and infertility, problems with fertility. This is important to discuss. People are spending hundreds and thousands of dollars to try to start a family, and we can give them the information or at least try to head them in the right direction to try to decrease that inflammation so they are successful in their process. Next, we talk about dementia. Brain health, and oral health. P. gingivalis is a very, very aggressive bacteria that exists in the mouth. It is permeable to the brain. It has direct links to dementia and Alzheimer's disease. This is a very important thing that you need to be knowledgeable about and explain and discuss with your patients. Also, periodontal disease increases the risk for respiratory disease. This is a big deal post-COVID. A lot of people have post-COVID respiratory issues. Understanding that controlling their periodontal condition could thereby help that is very significant. Lastly, colorectal cancer. This is very huge. Once you start practicing in the real world, you notice how many people have colon polyps. And what does that mean? Those are little corridors for aggressive bacteria to live in. Oral bacteria and gut bacteria communicate. So being able to control some of those aggressive bacterial levels will definitely help decrease the amount of negative bacteria in your gut. So just some important tools and information for you to have when you're talking about how oral health affects overall health. This slide is amazing because it literally lists all the bacteria. You can see the bacteria listed from purple all the way to green. They are color coded. These 11 periodontal pathogens are the most dangerous ones I had spoken about. So when you were born a clean slate. You have no oral bacteria. Your first interaction to these pathogens are with communication of saliva or sharing of instrument or tool with your parents. Some of this bacteria is contagious and some of it is resistant to cleaning. And a lot of it is linked to systemic disease. This is a cheat sheet that lists the most prevalent diseases on the left and which bacteria are associated with increasing your risk of the disease progression. This is very, very important as we're going to be talking specifically about some of these bacteria. The reason why these bacteria are color-coded is based on their danger level. AA is a very aggressive bacteria. It is marked purple because AA is very difficult to eliminate. It is the most dangerous and the highest risk marker for cardiovascular disease, which we will discuss later. EC and the green pathogens you see are the least risk because they are easily killed with a little bit of change of oral hygiene and some change in regimen in the dental chair. Those are easily eliminated, but important to understand which bacteria exists with which systemic disease. If there's one thing that you see as a pattern, you can see that PG and FN are the two bacteria that seem to be present in almost every single condition. FN now is showing links to Alzheimer's and dementia, but this slide has yet to be updated. SRP-resistant microorganisms. So here we have a patient coming in, and we're going to be the clinician that lets them know and educates them on their condition. I'm sorry, Mr. Smith, you have periodontal disease. Periodontal disease is a disease that involves the gum and the bone. We need to complete a scaling and root planing in addition to bacterial decontamination in order to decrease the amount of aggressive bacteria and stop the bone loss progression. As a clinician in the real world, you will go through all of that, but it's very difficult for patients to understand the difference between what a basic cleaning is, what their covered benefit is, i.e. a free benefit from their insurance, and what is actual disease, and at what point do we categorize that. What's important to understand from this slide is scaling and root planing alone will not eliminate all the aggressive bacteria. The most aggressive bacteria, which were red and orange and purple on the previous slide, do not die from scaling and root planing alone. That means they are debridement resistant. They will need chemicals or heat to kill them. This is important. Oftentimes, patients will forego the laser or the antibacterial decontamination because they want to save on finances. The truth is they're leaving with the most aggressive bacteria still in their mouth. Important to understand that. So what do we do and how do we test for this bacteria? How do we know if these 11 are present and how much of them are present, and how do we educate our patients? Well, the truth is there's lots of different ways to do it, and the way that we do in our practice is through oral DNA. Oral DNA is a chair-side saliva test. We take the sample same day and we send it out to a lab where it's processed. The lab will process for those 11 aggressive periodontal pathogens. Based on that report, we will get a bacterial breakdown on the levels of bacteria, how much is present and what type. In addition, we test one genetic marker, which is called interleukin 6. What is interleukin 6? Well, everybody in the medical and dental field wants to find a specific genetic marker that will measure inflammation. And a lot of studies have proven that interleukin 6 is actually a really great thing to look at. So when we test in our oral DNA panel and we test the patient's saliva, we only test for this genetic marker once because it doesn't change. It's part of your genetics. Whatever your result is the same. The bacteria might change in levels, but your IL-6 will always be a low, intermediate, or high. And what does that mean? Well, think of IL-6 as your body's response to trauma or disease. If you have a cut, let's say on your hand, and you are someone who has a high IL-6, your body overreacts to the trauma. The area gets swollen. You have delayed wound healing. It's basically an overproduction of your immune response that gets to the point where it could be detrimental to you because your immune response is overperforming. Whereas someone with a low IL-6 might have that same cut, but their immune response is much more efficient and acute and quick, thereby the progression or the long-term inflammation doesn't last as long and is not as dangerous. Patients with high IL-6 are the ones that I look at the most because these are the patients that oftentimes are the higher risk category for the systemic disease. Their body overreacts to any pathogen, and periodontal bacteria is oftentimes painless. So it's there silently and it's creating an inflammatory response that most patients don't know of. Most patients don't know if they have an over-exaggerated inflammatory response or not. So they don't have that information on their IL-6 gene. But in addition to that, they don't know what bacteria is in their mouth. So they could be walking around like ticking time bombs where they have high levels of aggressive bacteria that their body is overreacting to fight that never clears up, thereby setting the stage for different diseases to occur. This is a perfect example of what a test result looks like. I wanted you guys to actually see what a report looks like when it comes back. The left side of it that says my periopath is the section where it gives the biochemistry aspect of the bacterial profile of the patient. It lists that the myperiopath tests for the 11 most aggressive bacteria linked to periodontitis and other systemic diseases. And then the middle portion of the test that says myperio ID is actually the genetic part of the test that's not repeated. This helps us gauge how aggressive we have to be to our treatment response because we know how aggressive the patient's body will be responding to the bacteria. So you can also see from this test result that the color gradient is there on the danger level of the bacteria. You see that purple bacteria, AA, being the highest, most aggressive risk, as it goes down all the way to the red, orange, and green bacteria that ends up being low risk. One other thing I want each one of you to pay attention to as each bacteria actually has a black line associated with it. That's called our threshold line. Now, the threshold line for each bacteria is different because once that bar is past that threshold, essentially what it means is that bacteria is no longer encompassed only in the oral cavity. It is now actively in the bloodstream. How is this important as a clinician? Well, if you have someone who has high levels of high or moderate risk bacteria in their panel, and this bacteria is resistant, and it's at a level that it's above threshold, any treatment you do in the mouth alone will definitely not eliminate the entire bacteria because the bacteria in the blood will just go ahead and reinfect itself. So, important to know. And you'll notice when we go through our case examples, any bacterial level that's above the threshold line will indicate oral antibiotics. Anything we do to decontaminate in the mouth will not be sufficient because if the bacteria is in the bloodstream, we need antibiotics in the bloodstream to kill the residual. This is the results page that comes in the test, and I think it's important for you guys to understand what's presented to patients. The left side of the screen shows us an exact treatment plan that's recommended for the patient based on their bacterial panel. Most of the test results will list mechanical debridement. That is an indication for you to determine as a clinician whether that mechanical debridement is a full mouth debridement, a scaling and root planing, or a periodontal maintenance. And that, of course, depends on where your patient is and their periodontal history. The adjunctive therapies is the important part because the additional antibiotics and lasers and antiseptics that we use are the ones that are really going to be killing those most aggressive bacteria. As you remember, there are several bacteria that are SRP resistant, which means they're resistant to debridement alone. Scaling the root surface is not going to remove that bacteria. So that's where I get into talking about the whole mouth-body connection and gut health as well. So if a bacteria is above threshold, we'll be recommending those systemic antibiotics. Antiseptics and chemical hygiene is a combination of what you determine with your patients. Some doctors do perio trays, which are trays with medications in them. Others just prescribe a Paradex or a chlorhexidine rinse to be used. Lasers are definitely a non-medicated way, which is amazing because I'm a proponent of utilizing both non-medicated and medicated forms of treatment. Bacteria is smart. They will build resistance. So laser therapy is amazing. It's a game changer. It allows us to decontaminate pockets medication free, and patients need to understand the significance of that. But at the bottom of the recommendations, you'll also see it says localized probiotics and localized prebiotics because we know gut health is important, but a lot of times we know that pro and prebiotics taken specifically for the gut don't do a lot for the oral flora. So if you were not aware, there are actually probiotic pills, oral lozenges that will dissolve that were sometimes recommended to patients. And then we talk about a surgical referral because it's important we get a specialist involved in treating any disease. We want to make sure that we're doing right and we're being monitored by a periodontist. The right side lists the recommendations for this specific patient. Because this patient had bacteria above their threshold line, they have specific bacteria in their bloodstream, and that bacteria will need antibiotics to kill it. A recommendation of any antibiotic will be listed. And when you're ordering the test, you have the option as a clinician to list any antibiotic any patient might be allergic to, so you can avoid prescribing anything that's detrimental to their health. Often second or third choices are given to us in case a patient has been recently diagnosed or been given that antibiotic, so that we still have the same amount of efficacy. We might be changing the type of antibiotic not to have repetition. This is the last page of the report that a patient gets, and this is the money page because it lets them put their graph of what bacteria they have in their mouth side by side into what conditions they're at risk for, or perhaps heading down the road to. If there's family history of cardiovascular disease and you're 21 years old and you do an oral DNA and you have every cardiovascular aggressive bacteria in your panel, yet you have no signs of periodontal disease, are we still able to go in there and eliminate and decontaminate and perhaps get at the level where we prevent the disease from actually physically presenting itself? Yes, we can. And the science is there. And it involves educating patients so that they understand that the options are available to their children. One of the things we discussed about the high and moderate risk bacteria being SRP resistant, they're also contagious. What does that mean? That means you're a mom and you have a baby and she drops her pacifier and you pick up the pacifier and you lick it to clean it and you put it back in your baby's mouth. Well, if you have AATFTD, there's a very high chance you have transferred that bacteria to your child. Now, is the child's immune system going to clear it up? Possibly, yes, but repeated exposure to the same thing, add in an overreactive immune response, years and years of this bacteria seeping into our systems is causing some of these conditions. So this is a very, very great tool. This is something I discuss in my health history questionnaire with my patients. I actually bring it up and I ask them, hey, grandma, grandpa, aunt, uncle, anybody we should know that suffers from these, we need to pay more attention to your saliva. The next avenue of technology I use in order to provide medical dental integration on a whole different level of care to my patients that really sets me aside from my competitors is CBCT technology. When CBCT first was rolled out into my practice, I'm not going to lie, I was very hesitant in using it. I wasn't sure how much value it would add and if I wanted to expose my patients to that level of radiation. Oh my God, it is the biggest game changer in the world. Now that I know there's specific bacteria that can be very prevalent in increasing your rate of progression of systemic disease, I'm able to catch infections based on 3D CBCT technology before a patient has symptoms. And this is huge because Oftentimes in dentistry, we are in the business of repair. And once we actually have physical symptoms, it's very difficult to be the hero to repair that scenario. But if you had the added knowledge of being able to catch something in its initial beginning stages, you're able to change the trajectory of how that treatment plan actually works out. This is a great case example because I wanted you guys to see it. This is a patient that came into my practice complaining of pain on the lower left. The patient actually saw one of my new associates, and the new associate was unsure. The endo looks a little bit sketchy. So she came and she asked me, is it the root canal? Is it not? I see that the composite that's on number 20 is quite deep. I see the composite on 18 is deep. Are those the one leaking? Are they not? And so we said, okay, well, I can see from the 2D x-ray that there seems to be some pathology on the mesial and the distal root, but it seems a little bit unclear. Let's take a CBCT. Clear as day on the right corner, you can see the massive size of infection. A situation like this in the past, we might have adjusted the bite on the crown on number 19. We might have done an endo ice test on 20 or 18 to see if they need root canals. We might have had the patient come back 4 or 5 times, put them in a night guard, all of these different things until a fistula developed, until an abscess formed where we could physically see. Now we're able to say, hey, no, this is an infection. That's why you're having the discomfort. In the past, I used to observe infections like this because I was taught in dental school, if it doesn't hurt the patient and it's there, just observe it. We'll soon learn in a few slides that the bacteria that exists in these failed endodontic lesions actually double and triples your chance for a heart attack. So super important to understand what you're really observing and what you're not, because yes, the patient might tell you, doc, it doesn't hurt, but if they have cardiac history and they have cardiac bacteria, this is something I would not observe. So definitely uncovers more than 40% undetectable lesions. And now today, it's really awesome because AI technology has been incorporated into some of our radiographs. So it helps you locate some pathology and brings your eye into some things that you might not normally see. This goes into the detail that I was talking about. A study that was published in 2013 by Dr. Pessy shows that a whole bunch of heart attacks are actually linked to dental infections. And that's why I've mentioned this in the past, but patients that go to see a cardiologist and do a treadmill stress test, they're told they're fine, and then they're dying of heart attacks. Why? Because 78% of these clots actually have oral bacteria in them. Some of them are periodontal bacteria, and some of them are failed infected teeth bacteria, whether it's a decayed lesion that was never treated or a tooth that was in fact treated but failed. So very important to understand. As the population ages, and I know they mentioned to have a degree in gerontology. Gerontology is the study of adult development aging. And the baby boomer population is going to be the largest population of elderly individuals we've ever had. A lot of these people have had dental care only halfway through their life, started going in their early 20s. So they have failed lesions, they have dentistry that needs to be redone. And when you're going in as a clinician to redo a crown, if you don't know that that tooth has an abscess and you don't have that 3D technology, and you cut that crown off and later it's a problem for the patient, that patient assumes it was something that you did, when all along that tooth could have been infected, but you just didn't have the facts. You would have changed your treatment plan if you had the facts. And that's where that really comes into play, and it's important. And just understanding and looking at the patient's health history and their medical history and understanding what these bacteria might do to their overall health already makes you start thinking like a mouth-body connection doctor or clinician. The last tool I have in my toolbox is the beta that I tested. It's called AMMPA testing with the oralizer. This is the future, guys. This is stuff that's the standard of care in Europe already, and it's being used widely by periodontists all over and across the globe. What is AMMPA testing? Basically, this is a game changer because it doesn't go to the lab, it's straight there, and I'm able to get results in 5 minutes. I take a saliva test from my patients. I take a sample and I run it in the machine. And within 5 minutes, I'm given a number. That number will tell me how much collagen breakdown they have in their body. Why is this important? Because periodontal disease is cyclical. Sometimes it's active and sometimes it's dormant. We want to know how aggressive the tissue breakdown is. This is also a marker for total tissue breakdown, not just oral, which means if a patient has a failing knee, a failing hip, an autoimmune disorder, they have collagen breakdown happening. Their number will be high with this test, even if orally they seem healthy. This is actually a screening done by NASA before they send astronauts into space. They want to make sure they're not an active tissue breakdown in any part of their body so that they don't have any complications while they're far away. So really exciting because I was able to test it. My data is being recorded. A lot of dental insurances in the future are going to start allowing these tests to be done because of the work that we're doing. So it's very exciting. I have a quick video to share with you guys with the caveat that I might have some technical difficulties. Please bear with me. I think that it does a great illustration on what AMMP8 is and what we're measuring. So I'll play that for you now.
The mouth-body connection, how oral and systemic health are connected, and how the use of oral fluid diagnostics can improve patient health. The mouth is the gateway to the entire body. And healthy gums function as an immune barrier to prevent pathogenic bacteria from entering the body. Tight epithelial junctions in the gum tissue prevent oral bacteria from entering the bloodstream. However, a dysbiosis in the mouth can cause the body to produce elevated levels of active MMP8, an enzyme that acts like scissors to break down the gum tissue and destroy the tight junctions between epithelial cells, compromising the oral immune barrier. This results in what is known as leaky gum syndrome, allowing pathogenic bacteria and viruses to directly enter the bloodstream through the gums and spread to other areas of the body, such as the lungs, arteries, brain, and reproductive organs. The key to preventing this is to constantly monitor levels of AMMP8 and ensure that they stay in the healthy range with frequent visits to the dental hygienist and excellent daily home care.
Really great example. I see we have some questions. Let's see if we can ask them, answer them. Okay, looks like we're doing all right. Awesome. So this is the actual machine and this is what it looks like. It's from the company called Dental Genetics. So what is it? Again, it's a chairside test. It's a screening, okay? It doesn't help me diagnose periodontal disease, but it gives me a measurement reading similar to blood pressure to give an assessment on where the patient is at on their collagen level of breakdown. In society, we hear a lot about leaky gut syndrome. And now from that video, you were able to see what leaky gum syndrome is. It really doesn't start from the gut, it starts from the mouth. It leaks from in here, gets into the bloodstream, and gets everywhere. So really, really, really important to understand that connection. Now, I'm going to show you what an actual result looks like, and then you guys can see. This is what the patient goes home with, and then we give them a gradient. Any measurement from 0 to, I would say, below 20 is within normal limits. That's in the green borderline stage. That means the patient is not in huge active tissue breakdown, and that allows for us to be maybe a little bit more conservative with our care. If somebody comes in with any measurement higher than 20, then I'm a bit concerned that there is some collagen breakdown happening in their body, and I'm going to make extra recommendations on perhaps an oral DNA test to be done to see what aggressive bacteria they have, or share this information with them and recommend a retest after we've completed our therapies to see if the number lessens. Okay, so this is an example I have. This is a 50-year-old female patient. She came to me for a CCX back in February. CCX is called a recare exam. She had no complaints during her visit. You can roughly see her bite wings a little bit. You can see in the upper right bite wing that she's missing one premolar. There's a little bit of a larger gap there. A crown was down on that area to try to close some of that food trap. She also has an existing PFM crown with endo on tooth number 3 and some crowns on the left side as well. She had no concerns. She was very great with her oral hygiene, periodontally controlled. She was there for a dual appointment. Her last periodontal maintenance was in September, so it was 5 months after that she was coming in for another maintenance. During the exam, I talked to her about the new technology with the oralizer and the AMMPA testing, and we decided to take her sample. I was assuming her number was going to come out 0 to 20 and be normal because honestly, in her mouth, I saw no signs of disease and she had no pain. What ended up happening is she had a number that was 400. And I was like, what's going on? Is this machine broken? And that's where the doubts come in as a clinician. Anytime you're trying something new, you have to have the confidence to continue with it. And so we went one step further. We said, wait, we believe in the technology. Why is this number 400? You aren't having any pain anywhere. You're not due for a Panorex or a CBCT, but I need to investigate why. Let's figure out if this is dental or if this is medical. Let's take a CBCT and go from there. So that's what we did. We took a CBCT and sure enough, her root canal on tooth number 3, the mesial root, was failing. It's created an endodontic lesion that you can see is causing some fluid buildup into the sinus corridor. That is not great, and that is why she has active tissue breakdown. That's why the number was 400. Now, if this was 5 years ago, the patient would come in for a CCX. She would tell me she has no pain. I would look in her mouth. She would have nothing to diagnose. She would get her maintenance and she would be on her way until one day she would show up with a swollen face or a big fistula draining from her jaw. And so in this case, we were able to catch it and get in there sooner. She had mentioned she was having some pressure on the right sinus, so it all kind of came together and made sense. So the CBCT technology in combination with the AMMP8 really helped us figure everything out. Now we're going to go into specific examples because now that you understand the background of the technology, you can actually talk about case presentations and understanding some of the data that I'm going to share with you. So I want to talk about heart health. This is really important. This is a 35-year-old patient. This is most recent because you can see from this little box right here, this is our smart Epic chart. So Epic gives us some data points up front. So as a doctor, you have a little cheat sheet to look through what's going on. I can see what type of insurance the patient has, their blood pressure, their heart rate, what their next appointment is for, and what current medications they're on. This patient presented to me at 35 years old. He had just had a baby. And his main concern was, my dad died when I was young from a heart attack. I want to make sure I'm as healthy as possible. I want to make sure that I'm dealing with my oral health because I've learned there's connections. And I said, oh my God, I love you. Somebody's walking up to me already knowing and being educated on this. Let's go full force and figure out what your body's doing. You can see from his radiographs, it's nothing hugely significant. He has an open margin on the crown on number 31. It looks like maybe a retained root tip and the gum there on the distal from the wisdom tooth. He has some crowns on 12, 13, 14, 15. Looks like a larger periodontal pocket between 14 and 15. You can tell the patient's a grinder from his flattened teeth. But overall, even though he has the horizontal and localized areas of vertical bone loss, he is doing well with his oral hygiene. He's doing his brushing and flossing, and he had no bleeding on probing. He had no subgingival calculus. He basically had no plaque. And in the past, something like this is standard. You're like, okay, well, you're periodontally controlled. You're okay. Goodbye. Thank you so much. You have no problems. Well, no. Now we know about the mouth-body connection, and we're going to take this one step further. So we took his saliva test, and we did his oral DNA. What came back? He is a carrier of AA. AA, believe it or not, is really not a common bacteria. So when I see it in a panel, I am instantly alarmed. And not only does he have AA, he has it above threshold. It's past the black line, which means it's not only in his mouth, it's actively leaking in his bloodstream. On top of that, he has a total of 9 aggressive bacteria that are in his panel of the 11 that we tested for. And there's a second bacteria named TF above threshold as well, actively in his bloodstream. So this is all bad news as far as cardiac health is concerned, because the bacteria oftentimes associated with cardiac health are the ones that are purple and red. So AAPG, these are the ones, and FN that are linked to cardiac health. The second part of his test was very eye-opening for us too. He had a high IL-6. That means his immune response is going to be very aggressive to this bacteria. He could have walked around thinking he's completely fine, and this bacteria could have ultimately leaked into his heart or caused some sort of cardiac infarction. So I wanted to do some more research and took into some detail and shared this information with him. I said, I know you're periodontally controlled. I know I just told you you have great hygiene and you're doing great with your oral care. We talked about your bone loss, but even though you're presenting healthy in the mouth, there is bacteria there. We got to figure out a plan. So because AA is a cardiac bacteria, I went over the detail on here and I told him the significance of it. I've highlighted it here for you guys. AA is associated with a twofold risk of coronary artery disease. This is huge for someone who has a dad that passed away from a heart attack, right? Next, I go into his patient dashboard. This is something that my smart charts have with Epic. I'm able to take all of the data points that I collect and create a sheet or there's an app that patients can have access to their data. But why is this important? On the left column, you can see I have a blood pressure tab. We actually collect blood pressure every single time a patient walks in. And with this cool patient dashboard, I'm able to trend it. So on the bottom of this dashboard, this is the results of his bacterial panel. On the left is his blood pressure. Since I know AA is a cardiac bacteria, increases chance of heart attack, what did I do? I trended his blood pressure. What was it at? It's been consistently high. In the past, we were told 120 over 80 is healthy. Actually not. A little bit higher than that, double to triples your chance of heart attack. Now I have the family history of dad passing away. I have the presence of AA and TF above threshold. I have trends of high blood pressure. Everything is telling me this guy is signing up for a heart attack in his future. So getting this information has completely changed the way I treat him. In the past, I might have told him he's controlled and healthy. Now I know no, and that is not the case. So what was the indication for him? We did scaling and replaning again. We did laser decontamination. We did antimicrobial irrigation. We put him on 20 days of oral antibiotics. He got 4 quads of osseous surgery this week. I look forward to retesting him to see what the results are. Stay tuned if you join another one of my sessions. I wanted to bring another case example of cardiac health, and this is a very fast one. Unfortunately, it looks like my AMP8 marker reading fell off here. It's showing you a 4. The patient was actually 42 in her number. This is a 35-year-old female with no significant medical history, no medications that she's taking. The only family history she has is grandpa had heart disease. Well, she was periodontally controlled, actually doesn't even have bone loss. But when we took her CBCT, 2 things came up that relates to this panel, and I can tell as an investigator now that I have all the details what's going on. She has a failing endodontic lesion on tooth number 15 and a failing endodontic lesion on tooth number 30. Both of those have increased the level of AA, PG, TF, and FN in her body. Now, it's important to decrease these levels, but because this bacteria is linked to the endodontic lesions, it's important that these teeth either A, be retreated or extracted for the ultimate decontamination to happen. Next case example, we're going to talk about diabetes. I talked about the bidirectional relationship between diabetes and periodontal disease. If you improve one, the other one should improve. This is important. Why? Because everybody wants implants now. They think implants are the answers to everything. Guess what? Implant failures are happening. Osseointegration fails with patients who are not diabetically controlled. It is important as a clinician that you pay attention to overall health as well. You're signing your name to a restoration and adding liability without having the information that you need. This is a patient that came into me with the main concern that the lower right root, a tooth hurt. You can see that she has root caries, and I've circled it for you. She made a comment that she had 2 implants placed. One did great, and the other one, the doctor botched up and messed up and failed. And she asked me how great I was going to do, if I was going to be a winner or a loser in her implant game. I laughed a little bit because I was like, okay, well, let's figure out why this failed. Let's look a little bit more into your history. Let's take a look and see what's going on. Well, from her patient profile on the left, I can instantly see from her outgoing patient medications that she's on metformin. That means she's diabetic. I did an AMMP8 on her, and the number was extremely high. She's an active tissue breakdown. A patient with uncontrolled diabetes is setting up for implant failure. Until this patient controls her A1C, it's not about the dentist or the surgeon that places the implant. It has to do with whether her body is rejecting it or not. So this is how you kind of put all of those details together. This is her panel. You can see that of the 11 aggressive bacteria, 8 were present. Not only were 8 present, she had, I mean, 1, 2, 3 above threshold. So much bacteria in her bloodstream. And yet in her mind, the doctor that placed one implant was great, and the doctor that placed the other implant wasn't. But at the end of the day, it was really her body. This is her patient dashboard. I just love putting it up because this is a patient that has everything in play. I have the grading and staging of her periodontal disease. I have her oral bacterial panel listed for you guys. I have her collagen tissue breakdown and her oral fit. I have her trended blood pressures and heart rate. This is information that's important and will help me make sure she doesn't have a failure in the future. This is another example of a patient. This patient is pre-diabetic. Why is this important? So many people are going to be pre-diabetic, and can you make the difference in their health to prevent that diagnosis? Yes, you can, because the diseases are bidirectional. If you control this patient's periodontal disease, it will help her prevent or at least lessen the chance of progressing into diabetes. Really aggressive AMMP8 number, we're at 400. The tissue breakdown is outrageous. So someone like this, we need to SRP them and retest and make sure that these levels are low. Because this patient is younger and is not a candidate for osseous surgery, they will be controlled through oral antibiotics and scaling and root planing and decontamination alone and retested. Those that are candidates for osseous surgery are referred to the periodontist for osseous surgery before we administer the oral antibiotics. We find that the debridement from the SRPs, the decontamination from the laser, the final cleaning of the bacteria from the osseous, finished up by the oral antibiotics, is the best combination of care for the patients. Women's health. Women, so important. Not a lot of research done on women's health. Perimenopause, menopause, very big things. You need to know there are 3 major milestones in a female's life where oral bacteria changes and her body can become actually detrimental to her. That's during pregnancy, puberty, and menopause. Women with periodontal pathogens are higher risk for giving preterm birth, miscarriage, preeclampsia. It causes infertility. This is very important to understand because this is what patients care about. This is why they're going to choose you as a doctor for life, because you're pay attention to their overall health and how the oral health affects their body's health. FN is the bacteria that's at play. FN prevents a healthy pregnancy. FN is silent. It can be present in your body and not be pathogenic. And something like puberty or menopause or pregnancy can happen, and it can make that bacteria that's normally living dormant in your body become a huge pathogen that attaches more aggressive bacteria to it. Important to learn about FN. I wanted to share this case example because this is the most important case example to me. This is me. And I feel like if you understand my passion, you understand why I believe in the technology. I'm going to share my bite wings with you. You see, I have a lot of E1, E2 lesions. Should have flossed more while I was in dental school. I have a couple of composites. I have bone loss, generally horizontal, no subgingival calculus, no bleeding on probing. I always thought I was periodontally healthy. I brush, I floss, I water pick. I see my own hygienist regularly, assuming everything is okay. What happened to me? I had miscarriage after miscarriage, one at 9 weeks, the second one at 11 weeks, and my last loss was at 24 weeks of pregnancy. I had sent out baby shower invitations. I thought I was going to have a baby, and then I went to a conference to speak. It was a dental conference. I got off the airplane, my water broke, and I lost the baby. I had to figure out why was this happening? I'm healthy. My OB said I was healthy. Everything is okay. Why is this occurring? That's around the same time oral DNA came into my life and I decided to take my panel. I was shocked. I had FN above the threshold in my bloodstream. I've now done so much research on FN and I understand that once FN gets into your bloodstream, it can get into the placenta, it can infect the placenta, and can cause failure of the pregnancy. This changed the way I think about everything. If I am a dentist and I have the access to the best oral care possible, and I am putting my due diligence in my oral care, and I still have aggressive, systemic, contagious bacteria that's affecting my fertility, everybody is at risk to a certain extent. And that's why I want you guys to understand the importance of this. You can read the results. It said, infects the mother's blood and the placenta, causes premature delivery. I was able to control FN and became naturally pregnant. It's something I discuss now when I go to OBs and discuss the importance. I talk to patients in their fertility stage about the importance of controlling FN. This is my treatment plan. I was given 10 days of metronidazole. I also changed my lifestyle, started doing intermittent fasting, removed all inflammatory agents from my body. But I wanted to share this example because I think it's important you understand that as clinicians, we're not perfect. We're patients too. And by being open and honest with my patients about my own personal story, they understand I'm not judging them and I ultimately care about their overall health. Before we finish up really quick, I just wanted to show you a slide. I'm going to go over to this guy because this was a retest and we made a difference in this man's life. 72-year-old, history of heart disease, has had a heart attack. And what did we do? We tested him and we retested him. When you retest people, you're able to see the amount of decontamination that's happened. And in this case, you can see the bar graphs, how much we've decreased those aggressive cardiac bacteria that would have been very, very detrimental to his health. So to finish off, I just want to let you guys know why I test. I test not only to care about oral health, I care about systemic health. I am a clinician that wants to educate patients on their body and let them understand what is at their disposal so they can make educated decisions for themselves. And understand that you too have this power if you start to change the way you think about your treatment plan. So let's make a difference together. Any questions?
Excellent, excellent, excellent job, Dr. Najafi.
Thank you so
Please,
much.
if you have questions for her regarding anything that she has covered tonight, please, we do have a few minutes before we wrap up the webinar to ask those questions. There is a Q&A. You can just put your questions in that, and she'll be more than happy to answer those questions for you.
We also have a QR code at the end. You can scan that. We've been able to upload some patient data information sheets that you can have. It's information that I share with my patients. It's the AMMPH sheet and a cheat sheet on when and how and what to diagnose what saliva test. And feel free to email me with any questions. I'm very passionate about this. I want to learn more. If you have case examples, if you ever want to test yourself, let me know. I'm always available.
So you do have one question. It was, what is the cost to the patient for this testing?
The AMMP8 testing, because I was lucky enough to beta it, is $0 for every new patient. We're going to continue the $0 and the retest is $39. The oral DNA test is $199. And I let patients know I make zero money from the test. They can go on the Oral DNA website and order the test themselves for $299 and pay extra, or they can get the clinician discount. But once they understand in the long run how much it saves on medical bills, that cost is irrelevant, really.
And then a follow-up question. I'm not sure if you're seeing some of these questions.
I'm not.
Okay, so it's under the Q&A. It's not under the chat, but I'll go ahead and ask it. It is, being in Minnesota and a dental student, What would your advice to become more familiar with using these tests now or once practicing? So what's your advice on utilizing these tests?
I think the best bet, and I see these questions now. Thank you, Linda, for guiding me to the right
You're
place.
welcome.
I think the most important thing is to get familiar with your own family history and test yourself. The truth is, this is the beginning of something large. You guys have heard about companies like Viome. There's so many other companies doing saliva testing. Understanding your family history and what is going on with your body makes you learn more about yourself. Thereby, when you share that information with anybody, it comes across as confident because you've already done the research on yourself. So, with everybody, I say start with testing yourself. And then the name of the company that does the DNA test is called Oral DNA. You can go on their website. They do lots of different saliva tests. We actually do HPV testing. They're in the process of trying to figure out tests for maybe cancer biopsies in the future. That's what we're looking at, saliva being able to give us a biopsy on prerequisites to cancer and things like that. So definitely a great page to go on. Just get familiar. There's lots of informational tools. And then the AMMP8 testing is going to be only in Pacific Dental Services offices that have started it. It's being rolled out this year, and we believe it will be a new standard of care because Delta Dental and the American Dental Association is very interested as well. Thank you guys for that.
It looks like you've covered them all. Let me see if there was one more. There's one more. So we'll take this one and then we'll go ahead and you can give any last minute remarks, please.
This is the best question because it's very important. I only give antibiotics when it is above threshold and we are in the understanding that that is not the cure to your disease. I make it very clear in the beginning of this process with every patient. I am not a pharmacy to prescribe you antibiotics for the rest of your life. Your liver and your kidney cannot handle that. We can prescribe antibiotics with the conjunction of trying to figure out how we eliminate this bacteria. Some of it is surgery and some of it is not. That's why every single patient that is above threshold, that is a surgical case, is first sent to the periodontist. If they need surgery, they do it first. If he says they are non-surgical, then at that point, we're okay to go to drug therapy. But I am not in the business of repeating the same antibiotic over and over again. We got to figure out the root cause. Great question. And with that, I just want to say it's a new field. It's scary. Anything new is intimidating, but understand that it's growing and it's the future. And you can be the doctor that only places implants and only does veneers, or you can be the one that makes a difference in your patient's overall health and the legacy of their family. Understanding specific bacteria is contagious. Understanding we're spreading these systemic diseases to each other silently and slowly is definitely so important and will make a huge difference in the type of clinician you are.
Well,
So thank you.
I want to thank you, Dr. Najafi, and PDS Health for your support of ASDA. And for additional information on PDS Health, you can use this QR code on the screen. And also, this webinar was recorded tonight, so it will post within 1 week on ASDA's YouTube channel. I highly encourage you to share it, to review it again, and also share it with your colleagues and your peers and let them know about it so that they too can be informed. Thank you all for joining us and
Thank
have a
you.
wonderful evening.
Thank you so much.